Perfect. Okay, so our first speaker, she's online. She's joining us from Singapore, because that's where she works. Her name's Dr. Claire Pettitt. So Dr. Claire Pettitt is a UK Singapore registered dietitian working in both private practice and in academia. Claire has years of experience working across many areas of dietetics, including in the NHS, in research and in private practice. She has a special interest in women's health nutrition, especially in polycystic ovarian syndrome and fertility. So if Claire is able to join us online.
Yeah. There she is.
Hi, everybody. Can you hear me?
Yeah, that's perfect.
Yeah, wonderful. Thank you so much for inviting me today. It's really lovely to virtually be there. I know there's a lot of my wonderful colleagues from the maternal and fertility HARO fertility group, and I think there's a few other hands, maybe Kamal at the front there. I'm really sorry I can't be there in person, but as I said, yes, I'm based in Singapore. I'm going to just try and share my screen so you can see my slides. You don't want my face up there like that. Let's see. You can see that, right? Wonderful. So I'm going to talk to you today about PCOS. It's a topic that I'm really passionate about. So I'm known to talk a little bit too long, so I will do my best to try to be quick. To give you an introduction about me, well, in fact, I don't really need to because you've kind of heard it all already. I'm both UK and Singapore based. I've been through NHS, private practice, research. I've kind of experienced it all, but my love is really in women's health and especially PCOS. So that's what I'm going to talk to you today about. So I find that with a lot of my PCOS clients, they come to me and they are confused. So I thought today what we would do is a bit of a PCOS fact or fiction myth busting session. So in doing so, I'm really hoping that we kind of cover all the basics of, what PCOS is, give you a bit of an overview, look at its, pathophysiology, and look at diet and lifestyle advice in terms of the evidence base as well. So I will crack on with our first PCOS fact or fiction, which is that you need cysts on your ovaries to have a diagnosis of PCOS. Makes sense, it's in the name, polycystic ovary syndrome. So that's the first one. And I'm going to look at two at the same time. The second one is if your menstrual cycle is irregular, then you have PCOS. So basically, in order to answer these two, we really need to understand what PCOS is. I've moved my slide on. Oh yeah, there we go. We need to understand what PCOS is. So it is one of the most common endocrine disorders in women. So it affects around, well, it depends on the research, but between 10 to 25% of women. Also in the name, you can hear that it is a syndrome. So that's a collection of symptoms, which basically means it can look different in different people, which is partly why it can be quite challenging and confusing if you haven't got all the information around what exactly it is. And it also makes it quite challenging to manage and treat as well. So if we look at the Rotterdam criteria, which is the main diagnostic criteria that we tend to use. There are others, but this is kind of the most well-used criteria. You can see that there are three different criteria. One is oligo or anovulation, so a lack of a period or very irregular periods. And then we have hyperandrogenism, so these high levels of androgen hormones. Most common ones is testosterone. There are others that they will check as well. And then we've got this PCO morphology, so that's having the cysts on your ovaries. Technically speaking, it is not actually a cyst that they find. So to do that and to discover what your PCO morphology is, you need to have an ultrasound. And actually what it is follicles. They are follicles which have had an egg which has tried to mature, but there's not actually fully matured, and so it hasn't released. So it looks like cysts on the scan, but actually they are follicles. So that's where it gets its name from. Now, you only need to have 2 out of 3 of these criteria to get a diagnosis of PCOS. So you could have any combination of those three. So as well as those like Rotterdam criteria, if you've looked online, which is what everyone does these days, you might have seen these different PCOS phenotypes, and some like I guess in the more medical popular medicine articles, you'll see actually that they give them these phenotypes or types of PCOS. I don't always think it's that helpful, but it is based on the criteria. So you can see the picture on the left, this Venn diagram is basically giving you an idea of what those different phenotypes are. So in the middle is your PCOS, which has all three of those criteria. So you get hyperandrogenism, irregular periods, and the PCO morphology. If you have the classic PCOS, so the type B, then you would have hyperandrogenism and irregular periods. This one is probably the second easiest one to diagnose. The easiest one is when you've got all three. Then we've got your type C, which is ovulatory PCOS. So you tend to have the high androgen levels and the PCO morphology, but you don't have missed periods. So sometimes this is a bit easier to misdiagnose. And then we have the non-hirsute type, so irregular periods and PCOS, which is the most easily misdiagnosed and is often confused for things like hypothalamic amenorrhea, which is why when we think about whether or not having an irregular period should be an immediate conclusion that you have PCOS, well, no, there could be other things going on. And the thing about PCOS is also that it's a diagnosis of exclusion. So they do have to do tests to exclude other conditions that could be leading to high levels of hormones or irregular periods. So it's not something that should be taken lightly, and actually you should have full investigations done in order to get a diagnosis of PCOS. I think a lot of women who come to me with PCOS diagnosis not only confused but frustrated, and they have had enough of healthcare professionals who don't listen to them, they don't feel heard, and they don't feel that they've had their complaints taken seriously and fully investigated. So if you have PCOS, what would that mean in terms of your symptoms? So often we see people with PCOS, takes a few years to get a diagnosis, often not quite as bad as endometriosis, but they might present with some of these symptoms, and as I said, either not be taken seriously, not feel heard, and not get investigations completely done. So some of the symptoms they might experience, we've got the cyst on your ovaries. Obviously, you don't really experience that. It's not something you can see, but they would have that on the ultrasound. Often they have acne or hirsutism, which is that excess facial hair and hair growing on your chest and neck, which is the result of the high hormone levels. You can get struggle with weight gain, infertility, body image issues, even mood concerns, mental health issues. There's a link between PCOS and things like anxiety, depression. You often see that male pattern baldness. So it's not just about excess facial hair, but also you tend to get hair loss on the head in the pattern of male type balding. There is a little bit of a link between PCOS and gut issues, so dysbiosis, IBS. You also get this hyperpigmentation that you can see in the bottom right hand corner, and you also might get things like skin tags. Those two tend to be related to insulin resistance, which is, as we'll see later, part of the pathophysiology of PCOS. So there's so many different ways PCOS can present itself, and because of that, it can be hard to get a diagnosis. It might be that people are diagnosed in puberty, and actually that's a difficult time to diagnose because it takes a while for hormones to settle and periods to settle. So you might see actually that they don't get a full diagnosis. Then they might get the suggestion that they've got PCOS but aren't told you have PCOS. Often you'll see that people are diagnosed around the time of they want to conceive and they want to have a family. So it might be that they've been on the pill for years and they've come off the pill and they struggle, they don't get their periods back properly, or just that they don't seem to be able to conceive and they don't really know what's going on. PCOS can affect you throughout your life, so actually you could get a diagnosis at any time, but those tend to be the common times that you would see a diagnosis made. So that covers the first two fact or fictions, whether we need cysts on the ovaries and whether we need to have an irregular cycle. Let's move on to the next one. So again, I've kind of tried to group a few together, but the next one I think is a really, really important one, and that often people will say they feel like they did something to cause their PCOS. I think this is a really important one to address, because in terms of the cause of PCOS, the evidence isn't really that clear yet as to, conclusively what causes PCOS. There's lots of suggestions, and we know that there's a link in terms of genetics. So we often see that it runs in families. If your mum or your the women on your father's side have had PCOS, then you're more likely to have PCOS yourself. There's also a link between if your mum's had PCOS, then you're more likely to have had higher levels of hormones, insulin, etc., in utero, and so that could also have affected your risk of developing PCOS later on. So genetics, and then your environment in the womb. We know that there's also the link between environment, so lifestyle factors, and thinking about whether things like stress, diet, exercise, smoking, they've all been linked to an increased risk of PCOS. But it is ever one thing, and it's definitely important to highlight that it's not something that somebody's done, whether that's around their diet or their lifestyle, especially. So it's not something that someone can cause. Okay, the next one, that you won't be able to have a baby if you have PCOS. And if you don't want to get pregnant, then you don't have to worry about PCOS. So I thought these two were kind of linked. And actually, it really brings home the fact that often PCOS is just seen as a reproductive condition, and you'd only have to worry about it if pregnancy is something that's important to you, but actually, if we look at all of the comorbidities that you see in relation to PCOS, there's just a wide range of issues that could arise, especially around these three areas. So metabolic health, fertility and reproductive health, and then psychological health. So it is not just about having a baby or fertility. And so even if you don't care about having a family, it's not important to you, it's still something that you should manage. You should take control of your PCOS and look after your health. We see that women with PCOS have a higher risk of insulin resistance. They have around 80% of those with PCOS have insulin resistance. And that's irrespective of your body size. We've got higher prevalence of things like type 2 diabetes, cardiovascular disease. It's linked to, as we mentioned already, menstrual dysfunction and infertility, but also things like endometrial cancer. So even though not all women with PCOS want to have a baby, we also see that not all women with PCOS struggle with infertility. It is one of the comorbidities, but as we saw, there's different types of PCOS, and you don't necessarily have to have issues with your menstrual cycle. So not all women with PCOS will struggle with infertility, and some people will actually, we often see when they're first diagnosed that they're told, go away, lose weight, maybe go on the pill, come back to me when you want to have a baby, and we'll have a look at what we can do to help you. That, first of all, is based on a lot of myth, but second of all, it causes a lot of anxiety in people who, especially if they're diagnosed when they're young, and they then go on to think for the 10, 20 years even, gosh, I'm going to really struggle to have a baby, I'm going to have problems, and it could be a real source of health anxiety for them. So it's not helpful advice, and it's not true. So for some women, yes, it can be an issue, but there's so much that we can do to support them, but it's not true for 100% of people with PCOS. We also see a higher prevalence of things like nutrient deficiencies, sleep disturbances, so like sleep apnea, stress and anxiety, as I've already mentioned, disordered eating, higher incidence of negative body image, and you can really see from this that it's not just about reproductive function. Like PCOS is a complex endocrine disorder, and there's so many reasons that you should manage your PCOS aside from fertility. There have been some studies looking at the cost of PCOS, and if you look in the middle there, you can see that they've shown that there's this healthcare related economic burden of around $2.36 billion. So that was actually done in the States. That study is interesting because it showed that like the percentage or the proportion of that money that's spent in which areas. So 40% spent on metabolic health and diabetes, 30% on the more reproductive issues, 12% on infertility, and then only 2% is spent on the actual diagnostic side of it. So if we can increase awareness and we can try to get women diagnosed earlier, maybe they won't end up with all of these other issues and have to spend so much money in terms of healthcare perspective on managing PCOS. In the UK, there's a similar study, more of a modelling study actually, but I think they came up with an annual cost of £237 million. So not quite as high as that one, but yeah, more UK related study. So what is it that is causing all of these symptoms, and what is going on in the body? So these are the real main driving forces of PCOS. There are other things going on, but these three are the kind of big ones. So we know that in 80% of those with PCOS, we tend to see insulin resistance, and that's irrespective of body weight. Insulin resistance is really connected to the hyperandrogenism as well. So it tends to worsen, and they worsen each other actually. So there's a real link between the two. Insulin resistance also is really linked to an increase in worse metabolic health, so dyslipidemia, cardiovascular disease, type 2 diabetes, etc. And we see that if you have high levels of or high insulin resistance, you get these high levels of insulin, which basically can affect the production of your hormones, and those higher hormones will really lead to an interruption in ovulation, affect your menstrual cycles, may even have an impact on risk of miscarriage, things like that. So it might interfere with implantation. The high hormone levels are also a defining feature. So you often see that in about 80% of women with PCOS, and they are really responsible for some of those symptoms that we mentioned earlier. So the hirsutism, the excess facial hair, the acne, hair thinning, all those sorts of symptoms. So we know that the presence of the high hormones is linked to increase in insulin resistance and vice versa. So there's a definite link there. It's also linked to stress, inflammation, and other medical conditions as well. So inflammation is the third one, and we see in many women with PCOS that they have this low-grade chronic inflammation going on in the background. So if you were to measure things like CRP, it would just be slightly elevated. It wouldn't be so high that you know, in terms of what you would see in signs of infection, etc., but it'd just be this slightly elevated levels. And this chronic inflammation we know is associated with increased risk of insulin resistance. So again, another link there, cardiovascular disease, diabetes, and then having that inflammation impacts directly on your reproductive function. It can inhibit the maturation of the follicles and disrupt ovulation. So that's, again, linking back to the causes of PCOS, or those criteria, diagnosing criteria. And we know that it's also linked to disruption in terms of insulin resistance, endocrine pathways, and weight gain. So we're starting to see this picture of all those symptoms that women with PCOS appear with, and this is trying to understand why and how it's happening in the body. So this is painting you a picture of your classic client with PCOS. So they might present or suffer with irregular periods, facial hair, acne, weight gain, and cravings, and we've just kind of understood what's going on in the background with all of those symptoms. And often it does take around 2 years to get a diagnosis, and this leads to a real chronic cycle of dieting, you know, asking Dr. Google, what shall I do, and trying all sorts of different things but failing, and getting really frustrated and ending up with quite poor self-esteem. So they end up finally getting their PCOS diagnosis, and what are they told? So this takes me to our next fact or fiction, which is that weight loss is the best cure for PCOS. So this is probably the most common thing that my clients with PCOS hear, whether it's from their doctor or even from friends, family. This is the thing that they're mostly told. First of all, there's no cure for PCOS. It's different ways to manage the symptoms and the condition, but there is no cure. It is much more complex than just weight, and we've hopefully seen that when we've looked at all the underlying factors. And we also see that we have a phenotype of PCOS called lean PCOS. So this is basically where someone's weight or BMI is within a healthy range, yet they still have symptoms of PCOS and they get a diagnosis of PCOS. They also tend to have insulin resistance that's independent of weight, right? So they're not within those risky categories of BMI, and they still have insulin resistance. So it's not just weight that's an issue. But in order to answer this question in terms of what's the best way to manage it, I thought we would look at some of the guidelines and look at what the evidence says. Okay, so there are a few different guidelines out there. The most recent one is this one on the left, the International Evidence-Based Guidelines for the Assessment and Management of PCOS from 2018, and this is done by a team of experts. It's often called the Monash Guidelines because that's where they met and came up with them, but it is a whole team of experts in PCOS. They do recommend that lifestyle interventions are a really key part of managing PCOS. And in fact, those guidelines, the Royal College of Obstetricians and Gynecologists, they also recommend that it's done before attempting to use pharmacology. So really, lifestyle advice is the first line for PCOS management. So what do they recommend? So with regard to lifestyle, they really are suggesting that healthy lifestyle behaviors be implemented and followed. So that includes things like healthy eating and regular exercise, and that's in all people with PCOS. So whether you want to lose weight or not. Then if you do want to lose weight loss, to lose some weight, they suggest that a 5 to 10% weight loss is aimed for in 6 months, and that they should be referred on to get support with that weight loss. They also suggest using SMART goals, self-monitoring, and they mentioned that psychological factors should also be considered in terms of optimizing healthy lifestyle engagement. So bearing in mind things like anxiety, depression, body image concerns, disordered eating, etc. And they also highlight that it should be very patient-centered, and that's the kind of approach that we should use. So, you know, think about people's personal preferences, cultures, socioeconomic group, ethnicity, etc. Not news to any of you guys. So they do also specify that there is no one diet that's superior to any other in terms of managing PCOS, and that healthy eating principles apply. If you are trying to lose weight, then they suggest that you do that through a 30% energy deficit diet, or a deficit of 500 to 750 calories. So they say this, although they also highlight that for those who are in a bigger body, it can impact on their health and emotional well-being. And they also recognize this increased risk of eating disorders, poor body image, low self-esteem, etc., etc. We combine that with the fact that dieting probably also worsens some of those key players in the progression of PCOS. So, you know, dieting itself and yo-yo dieting especially can worsen your insulin resistance, can worsen inflammation, stress, and hyperandrogenism. So although it is recommended, it's questionable as to perhaps we need a little bit more guidance as to when it's appropriate. So it is the most common advice that people tend to receive, is to lose weight. It's kind of like the default, and the guidelines do suggest that weight loss can be helpful, but they do highlight that there's this increased risk of things like, disordered eating, etc. So the research, what does the research show us? It does actually show us that it can be harder for people with PCOS to lose weight. So if you look at studies that have tried to implement weight loss in people with PCOS, they tend to have a higher attrition rate, even compared to the general population. So like 50% will drop out, compared to in the general population weight loss studies, which are very challenging to do and often have dropouts. In the general population, it's 31% compared to 50% in PCOS. So it's definitely harder for people with PCOS to lose weight. In people with PCOS, we tend to see that it's often harder because of things like those cravings, insulin resistance and cravings, impaired appetite regulation, things like lower metabolism in people who have chronic dieting. And then they're also, on top of that, often given poor nutrition advice. So weight management is hard with PCOS. If you ask people with PCOS what their main struggle is, then it's the most commonly cited issue is weight management. And the majority of people with PCOS are on a diet. So although the most of them are, only about 15% of them will consult a dietitian, and most people will get their information from the internet. And that's, as I said at the beginning, a big source of confusion in itself. So definitely need some work there. We know that dieting can increase the risk of disordered eating, and that's no different in people with PCOS. So we see around 12 to 35% of people with PCOS have some kind of disordered eating, and especially high is binge eating behaviors, and that's often linked to the fact that they're told to cut carbs or go on restrictions, and they end up cutting out a lot of foods and having quite a restricted diet, not eating very much, and ending up quite hungry. Combine that with insulin resistance and carb cravings, and you're kind of setting yourself up for challenging cravings and binge eating. So it's definitely harder for people with PCOS to lose weight, and there's more risks associated with dieting. I mean, we see with weight cycling anyway, it increases risk of binge eating, and the research around dieting in anyone shows us that actually it can increase insulin resistance, it can increase inflammation, stress, etc., as I mentioned earlier. So is it really the best idea for people with PCOS as a general advice, right? That's what they all hear, but is that what they should be hearing? I mean, I would argue it's not. And I think on top of that, if you look at going back to the point I made about there being this lean phenotype, actually, if we know that people who are within a healthy BMI range also have the same issues, why are we not using the same advice that we would give to those with lean PCOS for those with those in a bigger body? So the recommendations around lean PCOS are basically suggesting that they maintain their weight, they try to follow an anti-inflammatory diet, they have a healthy dietary pattern, increase fruit and vegetables, maybe follow the Mediterranean diet, reduce saturated fat. Vitamin D is also important. So, I mean, this is healthy eating. It's nothing radical. So really, I mean, I think that's a really important question to ask for any condition, not only PCOS. Like if you were advising someone who was in a healthy BMI in terms of what advice you would give them, shouldn't really be that different as in terms of the basis of your advice. If they want to lose weight on top of it, fine. But actually, the basis of your advice should never be the first thing is weight loss. Okay, so we covered the weight loss issue. More specifically around dietary factors. So this is very, very common that are told that you have to have a low carb diet to manage your PCOS. Do you really have to? So this is very, very common, but there isn't really a lot of strong evidence for low carb diets in PCOS. There's the first study there is by McGrice, and that really is a systematic review from 2017. It shows that low carb diets could be helpful in terms of improving your reproductive hormones. It included 7 studies, so it's not a huge number of papers. This is actually part of the problem, is that we need more research in PCOS. We need to have more studies done and across the board in women's health. I think that's the case. And then we've got also this more recent meta-analysis from 2019, and they were looking at low carb diets, and they linked them to reduced BMI and also reduced insulin resistance. And this study had 8. This meta-analysis had 8 studies included in it, and you can see here that most of them had a macronutrient composition of 15 to 45% protein, 30 to 45% fat, and 20 to 45% carbs. The average was around 40%. So it's not actually that low if you think about it. So perhaps we don't need to be restricting carbohydrates in such an extreme way. And you know, people hear low carbohydrate diet, and that's they take the extreme end of that. So maybe we need a little bit more evidence around the amount of carbohydrate rather than just saying low carbohydrate diets. I mean, there's a lot of risk associated with true low carbohydrate diets. You know, they've got low fiber intake, low whole grain intake, and those are both really important in terms of reproductive function. So as well as bowel health, and we know that those, you know, can be issues in people with PCOS. So perhaps it is a moderate amount of carbohydrates that we need, and we need to focus more on the type of carbohydrate that we're having. So there is evidence supporting the use of a low GI diet, and this is commonly used to manage PCOS. It's linked to improvements in menstrual regularity, insulin resistance, hormone levels, improved body composition, fertility. So there's lots and lots of benefits to choosing a low GI diet in comparison to maybe just a low carb diet. In addition to the carbohydrate side, having a good balance is also important. So basically, when we add protein to low GI, what do we see? So if both diets are calorie controlled, then we see similar weight loss, but improved insulin resistance, improved insulin sensitivity as well. So actually, that's, you know, the goal shouldn't necessarily just be about weight. We're talking about the actual underlying physiology of what's going on in the bodies, and that's what we should be trying to improve. Higher protein diets are also linked to improvements in depression and self-esteem, and, you know, I've already mentioned that there's an increased risk of depression, anxiety, low mood, etc. in those with PCOS. As I mentioned earlier, you know, we do need more studies in this area, and this was looking at dietary patterns, this review from 2021, and actually there was only 7 studies included, so, you know, this is another area where we need more work, but they found that the studies were all quite different. They used different designs, different interventions, different durations, different outcomes, so it's very hard to compare. But what they did suggest is that actually the diet can impact PCOS, and what we should be looking at is things like low GI, lots of fruits and veggies, low fat dairy, omega-3, lean meats, healthy fats, legumes, whole grains, moderate alcohol. Again, not rocket science, it's all healthy eating. And it does also highlight the role of the microbiome. But I'm not really going to talk about that today. I don't have a lot of time. In fact, I'm probably running out of time. So this points us to the Mediterranean diet, which I don't need to tell you all about, but it is, in terms of studies in PCOS, has been shown to improve some of the symptoms of PCOS and reduce the risk of things like heart disease and diabetes. And that's probably, like, reduces inflammation. We know that's one of the underlying issues. So a Mediterranean style diet is encouraged. There are some other dietary strategies that you can use in people with PCOS with minimal amounts of evidence. Some of them are very small studies or very few studies, but I've just added some of them here. So for example, nuts has been linked to improvements in lipids and androgens, and when we include nuts in the diet. Cinnamon is another one, and there was a reasonably recent systematic review which showed that cinnamon can significantly reduce insulin resistance in people with PCOS. So often that's the strategy that I use with my clients. So adding cinnamon to your breakfast, smoothies or whatever. Spearmint tea has been linked to reduction in testosterone. So that's 2 cups of tea a day. And then there is a lot of work around supplements and probiotics. But again, I don't really have time to go into all of that today. So basically, we've seen that there's not one diet that fits everybody, and it really needs to be tailored to the individual. But what we do know is that we should choose our carbs wisely, aim for low GI, whole grains, high fiber, add protein and healthy fats, and consider a more Mediterranean style diet, including lots of fruits and veggies, oily fish, plant-based proteins over animal proteins. This is more around the lines of reproductive function and fertility. Include things like nuts, cinnamon, spearmint, tea, and then, as I said, probiotics and supplements can be useful as well. Now, as one more that I didn't yet talk about, and that's exercise. So often people will say, well, I'm going to have to run because, cardiovascular aerobic type exercise is the best for managing PCOS. If we look at the guidelines, what do they tell us? So the Monash guidelines will basically say that 150 minutes of moderate intensity or 75 minutes of vigorous intensity exercise, or a mixture of both, is good, including muscle strengthening activities on the 2 non-consecutive days. So body composition is important, and actually if we think about those underlying factors, insulin resistance, if we can improve our body composition, we can help to improve insulin resistance as well. There are, if you look at the studies that these suggestions are based on, there is evidence, actually it's quite contradictory in some cases, but there's evidence to say that aerobic exercise can help to improve things like testosterone, insulin resistance. There was a recent study looking at comparing moderate versus vigorous intensity exercise in people with PCOS. So that's the Pettitt study. And they basically found that actually HIIT exercises was potentially superior to moderate intensity exercise when it comes to insulin resistance, androgens, and then also cardiometabolic health, basically, in PCOS. And that was independent of weight. But as I said, there was also another recent systematic review, I can't remember the name now, but it was found the complete opposite. So I think exercise is another area where we still need more research. And I think highlighting the importance of strength and resistance training is important, and also doing exercise that you enjoy. There's also evidence around yoga, and it's been linked to reducing testosterone, insulin resistance, insulin levels. So really, when it comes to movement, the focus is trying to encourage people to move their body in any way that they actually enjoy. That over-exercising is not necessarily the best, because it can be linked to stress, inflammation, etc. But when you think about which type of exercise to choose, the one that you like and the one you're going to do is probably best. Find a way to help people to focus on the benefits of exercise outside of weight loss is also key. So even things like mood and improvements in lipids, insulin resistance are all linked to PCOS. So it's really key that they understand that exercise is not just about calorie burn. And then there's also, you see a lot in people with PCOS, so there's a lot of barriers to movement, and that's again around things like body image issues and weight and anxiety. So helping and supporting them in managing those as well is important. Okay, so in practice, really what we need to be doing is tailoring it to the person in front of us, tailoring our advice. So it depends on their presentation. So as I said, people with PCOS present in lots of different ways depending on their symptoms, their specific PCOS presentation. So you might use biochemical parameters to help look for improvements and use that as one of your outcome measures. Look at their comorbidities that they have and their medical history and see what's important to them. What is it that they actually trying to achieve? And that you need to do that bearing in mind, you know, what their eating habits are, their lifestyle, their stress, work-life balance, etc., etc. Weight loss isn't necessarily what people want. They want to, you know, improve their fertility or, you know, reduce their symptoms, or get rid of their cravings. So it really needs to be tailored to that person in front of you. There is no one size fits all approach. And I would encourage you to focus on health and not weight. So as I said, use biochemistry, body composition measures, health behaviors, and think about, you know, are they actually achieving 5 a day, or are they getting enough omega-3? Are they moving their body every day? And then think about, there's a lot of work actually done in the more psychological side of eating and why people eat the way they eat and what's led them to have the behaviors that they do now. So whether that's around their binge eating or the body image concerns, things like that. So it's a very holistic approach. And I think this kind of sums up that actually it's not just about weight. It's about, you know, sleep, movement, nutrition, self-care. And I think most people with PCOS need a lot more education around their condition, and I think that's why they come to you frustrated and fed up and you know, confused, because they don't really understand what's going on. And actually taking the time to really explain to them about their condition is really, really important, and helps them to make a change and change their behavior. And I also think that because there's such a link between PCOS and body image, binge eating, all those sorts of things, anxiety, depression, infertility even, I often think therapy can be very, very helpful. So I have, just to summarize, gone over all of my fact and fiction. They're all fiction, but they've hopefully covered all the signs and symptoms of PCOS, explain that there's no one diet that's superior, and actually it's you know, the evidence shows us that we need to tailor our approach to the person in front of us and hopefully focus not just on weight but on health, and be very holistic in our care. Thank you.